Hello. Human fungal infections have increased dramatically in incidence and severity in recent years, owing mainly to advances in surgery, cancer treatment of patients with lithorgan, and bone marrow transplantation. The HIV epidemic and the increasing use of broad-spectrum antimicrobial therapy in critically ill patients. For many years, amphotericin B was the only efficacious antifungal drug available for systemic use. While highly effective in many serious infections, it's also quite toxic. The antifungal drugs presently available fall into the following categories: systemic drug, oral and parenteral for systemic infections, oral systemic drugs for mucocutaneous infections, and topical drugs for mucocutaneous infections. First drug names amphotericin B. We know amphotericin A and amphotericin B. There are antifungal antibiotics produced by Streptomyces nodosus. Amphotericin A is not in clinical use. Amphotericin B is amphoteric polyene macrolide. It's nearly insoluble in water and is therefore prepared as colloidal suspension of amphotericin B and sodium deoxycholate for intravenous injection. Amphotericin B is poorly absorbed from the gastrointestinal tract. Oral amphotericin B is thus effective only on fungi within the lumen of the tract and cannot be used for treatment of systemic disease. Intravenous injection of 0.6 milligram per kilogram per day of amphotericin B results in average blood levels of 0.3 to 1 microgram by milliliter. The drug is more than 90% burned by serum proteins. Although it's mostly metabolized, some amphotericin B is excreted slowly in the urine over a period of several days. The serum half-life approximately 15 days. Hepatic impairment, renal impairment, and dialysis have little impact on drug concentration, and therefore no dose adjustment is required. And mechanism of action and about resistance. Amphotericin B is selective in its fungicidal effect because it exploits the difference in lipid composition of fungal and mammalian cell membranes. As suggested by its chemistry, amphotericin B combines widely with lipids along the double-bond ridge side of its structure and associated with water molecules along the hydroxyl ridge side. The pore allows the leakage of intracellular ions and macromolecules, eventually leading to cell death. Some binding to human membrane steroids does occur, probably accounting for the drug's prominent toxicity. Resistance to amphotericin B occurs if ergosterol binding is impaired either by decreasing the membrane concentration of ergosterol or by modifying the sterol target molecule to reduce its affinity for the drugs. Amphotericin B remains the antifungal agent with a broader spectrum of action. It has activity against the clinically significant years, including Candida albicans and Cryptococcus neoformans, organisms causing endemic mycosis, including Histoplasma capsulatum, plasmacystis dermatitis, and Coccidioides immitis, and the pathogenic molds such as Aspergillus fumigatus and the agents of mucormycosis. Amphotericin B is often used as initial induction regimes to rapidly reduce fungal burden and then replaced by one of the never azole drugs for chronic therapy or prevention of relapse. Therapy might be lifelong inpatient and high risk for disease relapse. Intrathecal therapy for fungal meningitis is poorly tolerated and fraught with difficulties related to maintaining cerebrospinal fluid access. So, intrathecal therapy with amphotericin B is being increasingly supplanted by other therapies, but remains an option in cases of fungal central nervous system infection that haven't responded to other agents. Local or topical administration of amphotericin B has been used with success. Mycotic corneal ulcers and keratitis can be cured with topical drops as well as by direct subconjunctival injection. Fungal arthritis has been treated with adjunctive local injection directly into the joint. Candiduria respond to bladder irrigation with amphotericin B, and this route has been shown to produce no significant systemic toxicity. The toxicity of amphotericin B can be divided into two broad categories: immediate reaction related to the infusion of the drug, and those occurring more slowly. Infusion-related toxicity. Infusion-related reaction are nearly universal and consist of fever, chills, vomiting, muscle spasms, hypotension, and headache. They can be ameliorated by slowing the infusion rate or decreasing the daily dose. Premedication with antipyretics, meperidine, antihistamines drugs, or corticosteroid can be helpful. When starting therapy, many clinicians administer test dose of 1 milligram intravenously to gauge the severity of the reaction. This can serve as a guide to initial dosing regime and premedication strategy. And next, cumulative toxicity. Renal damage is the most significant toxic reaction. Renal impairment occurs in nearly all patients treated with clinically significant doses of amphotericin. Abnormalities of liver function tests are occasionally seen, as is varying degree of anemia due to reduced erythropoietin production by damaging renal tubular cells. After intrathecal therapy with amphotericin, surgeries and chemical arachnoiditis may develop, often with serious neurologic sequelae. Next drug, flucytosine. Flucytosine is water-soluble pyrimidine analog related to the chemotherapeutic agent 5-fluorouracil. It's well absorbed, with serum concentration peaking 1 to 2 hours after oral dose. Is poorly protein bound and penetrated well into all body fluid compartments, including cerebrospinal fluid. It's eliminated by glomerular filtration with half-life of 4 hours and is removed by hemodialysis. Toxicity is more likely to occur in AIDS patients and those with renal insufficiency. Flucytosine is taken up to fungal cells via the enzyme cytosine permease. Resistance is thought to be mediated through the altered metabolism of flucytosine and thus uncommon in primary isolates. It develops rapidly in the course of flucytosine monotherapy. The spectrum of activity of flucytosine is restricted to C neoformans, some candida, and the dermaticose mold that cause chromoblastomycosis. Flucytosine isn't used as a single agent because of its demonstrated synergy with other agents and to avoid the development of secondary resistance. Side effect of flucytosine result from metabolism to the toxic antineoplastic compound fluorouracil, bone marrow toxicity with anemia, thrombocytopenia, leukopenia. There are the most common side effects with derangement of liver enzymes occurring less frequently. A form of toxic enterocolitic can occur. Next, the ropazoles, imidazole, and triazoles. Azoles, synthetic compounds that can be classified as either imidazoles or triazoles according to the number of nitrogen atoms in the 5-membered azole ring. The imidazoles consist of ketoconazole, miconazole, and clotrimazole. The latter two drugs are now used only in topical therapy. The triazoles include intraconazole, voriconazole, posaconazole, and fluconazole. The antifungal activity of azole drugs results from the reduction of ergosterol synthesis by inhibition of fungal cytochrome P enzymes. The selective toxicity of azole drug results from their great affinity for fungal than for human cytochrome P enzymes. Imidazoles exhibit a lesser degree of selectivity than the triazoles, accounting for the higher incidence of drug interaction and side effects. Spectrum of action of azole medication is broad, including many species of cyanoformans, endemic mycosis, candida, dermatophytes, and in the case of intraconazole and voriconazole, even aspergillus infection. The endemic mycosis including blastomycosis, coccidioidomycosis, and histoplasmosis. As a group, the azoles are relatively non-toxic. The most common side effects is relatively minor gastrointestinal upset. All azoles have been reported to cause abnormalities in liver enzymes and very rarely clinical hepatitis. All azole drugs are prone to drug interaction because they affect the mammalian cytochrome P system of enzymes to some extent. Ketoconazole was the first oral azole introduced into clinical use. It's distinguished from triazoles by its greater propensity to inhibit mammalian cytochrome P enzymes. That's it's less selective for fungal P than the never azoles. Intraconazole is available in oral and intravenous formulation. Drug absorption is increased by food and by low gastric pH. An important drug interaction is reduced by availability of intraconazole when taken with rifampicin. It's rifampicin, rifabutin, rifampin. Like ketoconazole, intraconazole penetrating poorly into the cerebrospinal fluid. Intraconazole is the azole of choice for treatment of disease due to the dimorphic fungi histoplasma, Sporotrix, blastomyces. Intraconazole has activity agent aspergillus, but it has been replaced by voriconazole as the azole of choice for aspergillosis, and intraconazole is used extensively in the treatment of dermatophytosis and onychomycosis. Fluconazole displays a high degree of water solubility and good cerebrospinal fluid penetration. The drug is available in oral and intravenous formulation. Fluconazole is the azole of choice in the treatment and secondary prophylaxis of cryptococcal meningitis. Voriconazole is available in intravenous and oral formulation. The drug is well absorbed orally. Metabolism is predominantly hepatic. Voriconazole is clinically relevant inhibitor of mammalian cytochrome P3A4 and dose reduction of number of medication is required when voriconazole is started. These include cyclosporin, tacrolimus, and HMG coenzyme A reductase inhibitors. Observed toxicities include rash and elevated hepatic enzymes. Visual disturbance are common. These visual changes usually occur immediately after a dose of voriconazole and resolve within 30 minutes. Photosensitivity dermatitis is commonly observed in patients receiving chronic oral therapy. Next drug, posaconazole. Posaconazole is the newest triazole. It's available only in a liquid oral formulation. Posaconazole is a broadest spectrum member of the azole family with activity against most species of Candida and Aspergillus. It's the only azole with significant activity agent, the agent of mucormycosis. Is currently licensed for salvage therapy in invasive aspergillosis as well as prophylaxis of fungal infection during induction chemotherapy for leukemia and for allogenic bone marrow transplant patient with graft versus host disease. Echinocandins as a newest class of antifungal agent to be developed. There are large cyclic peptides like the long-chain fatty acid, micafungin, caspafungin, and anidulafungin. There are the only licensed agent in this category of antifungals. Also, other drugs under active investigation. This agent active against Candida and Aspergillus. Echinocandins available only in intravenous formulation. Caspofungin administered as single low dose of 70 mg, followed by a daily dose of 50 mg. Caspofungin water soluble and highly protein bound. Half-life is 11 hours, and the metabolite excreted by the kidneys and gastrointestinal tract. Micafungin displays similar properties with a half-life of 15 hours. Anidulafungin has a half-life of 24 up to 48 hours. Echinocandins act at the level of the fungal cells while inhibiting the synthesis of beta 1-up-3 glucan. This results in the disruption of the fungal cell wall and cell death. Echinocandin agents are extremely well tolerated with minor gastrointestinal side effect and flushing reported infrequently. Micafungin has been shown to increase level of nifedipine, sirolimus, cyclosporin. Anidulafungin doesn't seem to have significant drug interaction, but histamine release may occur during intravenous infusion. Next part of our lecture is oral systemic antifungal drugs for mucocutaneous infection. Griseofulvin is a very insoluble fungistatic drug derived from a species of penicillium. Its only use is in the systemic treatment of dermatitis. Absorption is improved when it's given with fatty foods. Glycofulvine's mechanism of action at the cellular level is unclear, but it deposits in newly forming skin where it binds to keratin, protecting the skin from new infection. Because its action is to prevent infection of those new skin structures, glycofulvine must be administered for 2 up to 6 weeks for skin and hair infection to allow the replacement of infected keratin by the resistant structures. Nail infections may require therapy for months to allow regrowths of the new protected nail and is often followed by a relapse. Side effects include allergic syndrome, much like serum sickness, hepatitis, and drug interaction with warfarin and phenobarbital. Terbinafine is a synthetic allylamine that's available in oral formulation. It's used in the treatment of dermatophytosis, especially onychomycosis. Terbinafine is a keratophilic medication, but unlike rhizophulvine, is fungicidal. Side effects are rare, consist primarily of gastrointestinal upset and headache. And next part, topical antifungal therapy. Nystatin is polyene macrolide, much like amphotericin B. It's too toxic for parenteral administration and is only used topically. Nystatin is currently available in creams, ointments, suppositories, and other forms for application to skin and mucous membranes. It's not absorbed to a significant degree from skin, mucous membrane, or the gastrointestinal tract. As a result, nystatin has little toxicity, although oral use is often limited by the unpleasant taste. Nystatin is active agent, most candida, and is most commonly used for suppression of local candidal infection. Some common indications include oropharyngeal thrush, vaginal candidosis, and intertriginous candidal infection. The two azoles most commonly used topically are clotrimazole and miconazole, both available over the counter and are often used for vulvovaginal candidosis. Oral clotrimazole thrush available for treatment of oral thrush and pleasant tasting alternative to nystatin. In cream form, both agents are useful for dermatophytic infection, including tinea corposis, tinea pedis, and tinea cruris. Absorption is negligible and side effects are rare. Topical and shampoo form of ketoconazole are also available and useful in the treatment of seborrheic dermatitis and pityriasis versicolor. And last, topical allylamines, terbinafine and naftifine. There are allylamines available as topical creams, both effective for treatment of tinea cruris and tinea corporis. So you can see these tables with short information about all antifungal drugs with forms and dosage. And last slide with information about mycobacterial drugs. Mycobacteria intrinsically resistant to most antibiotics because they grow more slowly than other bacteria. Antibiotics, they are most active agent, rapidly growing cells, relatively ineffective. Mycobacteria cells can also be dormant and thus completely resistant to many drugs or kill it only very slowly. The lipid-rich mycobacterial cell wall is impermeable to many agents. And mycobacterial species, intracellular pathogens, and organisms residing within macrophages inaccessible to drugs that penetrate these cells poorly. Finally, mycobacteria notorious for their ability to develop resistance. A combination of two or more drugs required to overcome these obstacles and to prevent emergence of resistance during the course of therapy. The response of mycobacterial infection to chemotherapy is slow and treatment must be administered for months to years, depending on which drugs are used. And I said next time about the treatment of tuberculosis. It will be in next lecture. Thank you for your attention.